The ADAURA results that I presented at ASCO truly are a new paradigm for the treatment of non-small cell lung cancer. It really takes the best of targeted therapy, and that's EGFR inhibition using osimertinib, a third-generation drug, and combines it with multimodality therapy, surgery, and chemotherapy for early-stage lung cancer. So what we did in ADAURA was we used osimertinib in a randomized trial, a worldwide trial, 2/3 of the patients in Asia, 1/3 in the West. Patients after appropriate surgery, complete resection, and chemotherapy, if appropriate, were randomized to either osimertinib, 80 milligrams a day, or a placebo. 680 plus patients in the trial, phase 3 study. In the primary population of patients stage 2 and 3A, the hazard ratio for DFS, disease-free survival, was 0.17, with the highest statistically significant p-value. And then when you added the 1 patients in, 1, 2, and 3, and the trial was balanced with about 1/3 of the patients 1, 1/3 2, and 1/3 3, the hazard ratio was 0.21, just slightly increased, even when adding all those patients with stage 1 disease, which had such a good prognosis to begin with, also highly statistically significant. Then, importantly, toxicity-wise, the drug was well tolerated, no more than a very slight increase in toxicities, very consistent with what has been seen with osimertinib, this third-generation EGFR TKI-specific drug in prior studies such as FLAURA, which of course has made it the standard of care in most places in advanced disease. So that was very, very exciting. I personally think that now we'll see other targeted agents being used in the adjuvant setting, and it really speaks to the fact that precision medicine, initially developed in the most advanced refractory settings, moved to first-line metastatic disease, is now moving to the adjuvant setting, and a lot like what's happened in breast cancer with Herceptin. That's more than 15 years now. But the same idea, to use a targeted drug in a population of patients. Lung cancer is the most common cause of cancer death worldwide. More than 2 million people have lung cancer or get lung cancer a year in the world. So there are many patients with EGFR mutations, 10 to 15% in the US, maybe 20 to 30% in Asia and elsewhere. So this is going to be very applicable and hopefully help patients. As we await more data, of course, this trial will be followed now for survival. We hope soon to have data regarding local and regional and distant recurrence. As we know, metastases are what can kill patients with lung cancer, and I'm very eager to see the results for the number of brain mets, liver, bone, metastases to the other lung, because my suspicion is this will show that patients are living with better quality of life because the cancer is not recurring in these very sensitive sites. This trial was placebo-controlled, and you don't see too many of those anymore, except in situations where there is really no other standard of care, and that's the case here. Other drugs, erlotinib, and has been studied in this setting in the trial known as RADIANT, maybe a decade ago, and it was negative. The drug wasn't well tolerated, and there was no benefit. The hazard ratio in that trial was 0.6, 0.7. So with no standard of care, placebo was the appropriate control, and it won't be anymore. Absolutely. So I was trained at Dana-Farber by Emil Frey, Tom Frey, among many mentors I've had. And he always used to sit me down and say the best thing to do is always move your best drugs earlier and earlier in disease. And in those days, the drugs were cisplatin-based adjuvant chemotherapy. And we've seen that chemotherapy always works better when you use it earlier. Patients are healthier, stronger, can do better. Now we have a targeted therapy. We've moved it from the metastatic setting to the adjuvant setting. Yes, why not use it up front? Maybe we can use it and shrink a tumor, do a smaller operation, save a patient, some lung function, allow surgeries to happen that couldn't have happened before. When you do a neoadjuvant procedure, you actually get the whole tumor out. You can see how effective things have been. You'll know if it's been effective. Maybe you continue it in the adjuvant setting. Maybe you combine it even with chemotherapy. There was at one point, those trials, actually, I ran many of them 20 years ago. We didn't use chemotherapy with EGFR inhibitors, but now that we know the mutations, I think that might be different, and maybe there's a role for both. So yes, that's very exciting. Those trials are already going on. I suspect you'll be seeing it pretty soon.